Okay, so we're going to talk about burns. I guess for my binoculars, my name is Dr. Jordan, and we're going to talk about burns today. These are our objectives. We're going to define burns, pathophysiology, we're going to the types of burns that you can have, what do you do with the wounds, how in the world are you going to treat this. We're going to talk about the rule of nines. If you haven't heard about what that is, learn how to calculate the extent of your burn, and then how we're going to resuscitate that with fluids using the Parkland formula. And then we're just going to discuss the management of those burn clients. So burns, as it is defined, is basically it's cellular destruction of the layers of the skin and the resultant depletion of fluids and electrolytes. What do we know about the skin? Thermoregulation. Okay, so it keeps us thermoregulated. If we're too hot, it sends up some fluid, right? And cools you down. If we're too cold, it pushes our hairs together and constricts and maintains our heat. It also protects us from what? Infections. It's the largest organ that we have, and it protects us from infection, heat, and cold. So very good. So when you destroy that layer of skin, it sets you up for all those things we just talked about. You're not able to regulate. You're not able to be protected from infection, and it also is. It also depletes those fluid and electrolytes when you destroy tissue. So we'll get into that in just a few minutes. But here's your tissue layers in case you had forgotten. You have an epidermis, that's the very top layer of your skin. And below that is your dermis. And as you can see, the dermis has the capillary beds in there along with the nerve endings. The nerve endings go all the way up to the top into that dermal layer. And that's why when we touch something hot, we want to pull back immediately. Something that hurts in any way, shape, or form, we want to retract from that. It's on that very surface layer of our skin. Under your dermis is the subcutaneous tissue, which some of us have a little more than others, but it's okay. And that's where basically that insulation comes in as well. So these are the different layers of your skin. Below that is what? And below your fat is what? Muscle. Below your fat is muscle. And then you've got tendons, ligaments, and bone. Can you have a burn that goes all the way down to the bone? Absolutely you can. We'll look at some of those as well. So you have to know your tissue layers in order to understand the depth of those burns. Now, as you can see on the right, it says first, second, and third degree. Those are some old terms, but you're still going to see those terms, and you're going to hear those terms. So we'll go over those as well. All right, so the pathophysiology of burns is basically the skin comes in contact with some type of burn agent, and the cells denature. What does that mean? What is denature? They breaks them down. It destroys them. Whatever is in those cells are then released. Okay? Keep that in mind. So it breaks down those cells. And then you have an inflammatory response. That inflammatory response, as we learned with SIRS, can cause some damage, and it can further the damage. It sends out all the cytokines. Remember all that happens? Tissue factor, all that comes to the surface there causes you to have this inflammatory response, which then can produce greater cellular damage. And it continues until the heat is taken away. So you don't have to have major burns, you can have minor burns, but major burns, initially you had that burn shock period. So what happens is, if you have a large part of your body that has these burns, typically the top layer is not an issue. It's when you get into that dermis and subcutaneous tissue that you start having the bigger issues of fluid and electrolyte imbalances. You will have a vasodilatation response. So you'll go into a shock, a hypovolemic and a distributive shock with burns. Okay, so that's the problem, and that actually is what kills our patients initially. So you have a major burn, and basically you go into a shock state. What causes a shock? What causes this? Well, as you know, SIRS is just a systemic inflammatory response. So if you have a good part of your, over 20% typically, of your body that's got a second, third degree burn, you've lost a lot of fluid. So hypovolemia immediately sets in. But then with the inflammatory response, it sends out all of those receptors out, which then cause more damage. And it also causes your vessels to get permeable. Remember that? So we're still leaking stuff out. So we don't have enough in our vascular space to give the nutrients to the other organs and other tissues as well. So we are in a shock state at that point. And that's what we have to do. We have to save our patient from this shock stage initially. So you can see it as start as a SIRS, and it goes into a shock. Shock then leads in, if you don't fix it, it's going to go into a MODS because we're not perfusing those vital organs. We don't have enough cardiac output, enough oxygen for those our organs. So past that, there is a hypermetabolic state. Anytime you need an increased amount of oxygen to the tissues, an increased demand, you're going to have a hypermetabolic state. Anytime that you denature muscle and tissue, which is made up mostly of protein, you're in a hypermetabolic state. And that's why usually when you're really, really sick, we're trying to feed you early on. We're not keeping you NPO for very long because you really need those nutrients to help secure those tissues' health, right? That's how we actually put our nutrients back in there and it forms new tissue and we move on. So you not only have this hypoperfusion state, but you also have a hypermetabolic state. All right, so it's very important for you to know what happened, when it happened, how it happened. You have to get the backstory on these burn patients. Very important. So you have to know the history of the burn. What caused the burn? And we'll talk about the causative factors in just a minute because there's multiple, right? The temperature of the burning agent. If it's very, very hot, then you're going to have a deeper burn immediately, right? Immediately. So you have a pot that's been on the stove. It's set off to the side. You have the stove with the eye that's actually red and hot. Which one's hotter? Probably the one that's actually got the heat to it right now, full blast. So if I touch one versus the other, the one that's got the most heat is going to give me a deeper burn a lot faster than the other one is. So the temperature of it is very important as well. Duration of contact, obviously if I just kept my finger on something that's burning me, it's going to be a deeper burn as well. Thickness of the skin. There's areas of your body that's the thickness of the skin is a lot thicker versus another area which is a lot thinner. So you'll have a deeper burn if the area that you're burning, like around your eyes here, if that was burned, it's very thin. Well, it wouldn't take much to get down to the subcutaneous tissue and potentially the bone. Whereas if you burnt my arm, I mean, I've been out in the sun quite a bit, you know what I'm saying? So I got like some thick tissue or whatever. It's gonna take a whole lot longer. That causative factor would have to be on there a little bit longer before it's gonna go down into the subcutaneous tissue and ultimately the bone. So it depends on how thick your skin is, as far as how deep it's gonna be. These are your causes or your types of burn, and this is what you need to know. Because it's important for you to know, is it just the sun? Is it a sunburn? So is it a thermal burn, which is most common, right? We use curling irons, ladies, right? I straightened my hair today. I don't know how many times when I was growing up, I put a curling iron on my ear. I don't even know. I'm surprised I have an ear on either side. Always burning my neck, always burning my ear, learning how to curl my hair. But so thermal's the most common, and usually while we're cooking or barbecuing, just burning the track, whatever. So typically it comes from thermal. Steam is another you might want to think about as well, because we don't really think about steam as often. But just hot liquids. Now that everybody uses a microwave to cook with. I mean, almost everybody, right? So we usually stick something in there, we turn it on, we leave, we come back, we get our whatever it is. So as I was raising my kids to cook with the microwave, which was wonderful because they have the little macaroni packs, right? You fill it up with a little water, shove it in there, it tells you which one, how many times to press the positive, which is 30 seconds. I'm like, yeah, 4 times, good to go, right? Well, that's great and all, except when they start pulling that out, that macaroni is really hot. My best friend's daughter pulled the macaroni out and it fell on her foot. Well, it was really hot, and she was only like 4. So it was really bad because that macaroni covered her whole foot, and she was so tiny. She wasn't supposed to be taking it out. She wasn't supposed to be cooking with the microwave, but she did. She cooked her own. She was like, I'm hungry. You know how kids are. She went there and cooked her some macaroni, tore the thing open, put some water, didn't even have, she overflowed the water, and then she just kept pushing the button. I know she did, because it was a lot. But anyway, so just those type things coming in contact with the skin. And even for that length of time where it just splashed on her, and then, I'm sure it cooled off. Or the coffee from McDonald's that got everybody sued, that everybody sued over the coffee, now has the little caution on it. If it's hot enough, it's gonna do some damage immediately. So that's our most common, and that's what we think of most of the time. However, smoke inhalation you don't really think about as a burn. But smoke inhalation, when you have a smoke in a confined area, and it's coming from something that's being burned, and that particulate that is in the air with that smoke, if you breathe it in, it's hot. I'm sure everybody's kind of experienced maybe a smoky session, but if you're close to the fire, or it's a very large fire, and you're breathing in that particulate, it's very hot, and it's going into your respiratory tract. And that actually is what kills people, not necessarily being burned, but in a house fire, 9 times out of 10, they actually die from smoke inhalation. So, but basically, it's just super hot air. Chemical, most of the time when I see chemical burns in the emergency room, it's usually stuff that we use around the house every day, cleaning stuff. And my mother was a muriatic acid user, man. She loved some muriatic acid. We moved around a lot when I was a kid, and still don't like her for that to this day, but I do love her. But we moved around a lot, and so we would rent a house. We'd live there for a while and move again. Well, girl, we were gonna clean some tubs and stuff, and she cleaned with muriatic acid. She didn't want anybody's cooties, right? Like, good Lord. But I remember there were a few times where she had been in there for a while and didn't have enough ventilation. So she'd come out looking all kind of crazy, like just red and blotchy. And I remember her hands being really red and skin would peel off of them. Now I'm like, there are gloves. I mean, they don't use that stuff. But typically when we're seeing chemical burns, that's what we're seeing in emergency room. Just people are using bleach and those type of things, and they're not wearing gloves. So they'll get burns that way. There are a few accidents that's happened around here on farms where they have come in contact with some kind of causative agent or caustic agent that has gotten on them. And what we usually do is we decontaminate them. Now, as a nurse in the emergency room, when you come in, when the patient comes in, you have to be fully dressed out if it's a decontamination process. There is a room, we take you to the room, we shower you off, okay? So we stop the burning process of that causative chemical just by getting them under the water. We are also dressed out, fully gloved, mask, everything, so then we don't get splashed by this chemical as well, right? So acids and bases can cause that. A chemical ingestion occurred right out of school. I was working at Decatur General, and the police brought in a homeless man, and he was foaming at the mouth. They didn't know what was going on, but they brought a bottle with him. He was walking through the park. I mean, this doesn't sound like a movie, but he was walking through the park, saw a bottle, drank some of it, and it was some kind of caustic agent. It wasn't booze or water or whatever. And he basically just burned the whole inside of him. He did not make it. We intubated him immediately, but he did not make it. He literally just burned himself from the inside out. It was awful. So you can ingest those chemicals. Electrical, those are those wannabe electricians. You know, like, you should probably hire somebody if you don't know anything about electricity. You don't need to be playing with it. However, there are people like my uncle who was an electrician who was putting in a ceiling fan. It was hot in the attic. I don't know. He's probably put in 1 million ceiling fans for other people. We don't know what happened, but he got electrocuted and it killed him immediately. He had a heart attack. So that electrocution typically, the problem is that your heart is a cardioactive, it runs by electricity, right? And so it attracts that, and your neurons are run by electricity. So those attract that electrical current, and it's going to send it all the way through you. It's going to send it through your heart. And 9 times out of 10, it causes VFib or VTAC. And if you're not there to defib, then they go into asystole and they die. So electrical current is one that's really interesting because you'll have an input and an output. It's going to go to ground. So a lot of times it's on the hand because that's what we do, right? Goes through the hand, through the body, out. A lot of times the feet. Doesn't have to go out through the feet, but a lot of times it's out the feet. So you want to find out where the input is and try to find out where it went through. Just so then you kind of have an idea of what kind of damage it might have done. And the last one is radiation. Those are like x-rays. X-ray, radioactive source, and so I'm sure you've been around people in the hospital that work for in the X-ray department, and they have little badges, right? And it is radiographic material, and they can only have a certain amount, and then they can't work. They can't work back there, so they'll pull them out, and they'll have to do other functions instead of doing X-rays and MRIs and those type of things. But you can have some radiation. Hopefully we won't ever see any radiation from our nuclear power plants around here because we'll all be dead. Just saying. Ultraviolet rays, is also a type of radiation. How do we usually get our ultraviolet rays? From the sun. I'm sure that the people who live and work in the hospitals in like Florida and California and those type of places see a lot of radiation through their ERs because we see it here. We had one gentleman that came in and he actually drove himself back from the beach, but he literally was red from head to toe, except for his little privacy area, head to toe, swollen, pain. Well, we're only there for a little while. We just gotta get lunch, you know. Yeah. So obviously sunscreen. When you're teaching your patients how to prevent burns, it's going to be all of this stuff right here because this is what's found in their house. So you want to make sure that curtains aren't near fireplaces and that you've got little electrical plugs so your children don't stick stuff in them, and you want to wear the sunscreen if you're going to be outside. So these are the things that you're going to teach your patients, especially your parents. Yes, it is a radiation ray because it's ultraviolet rays. Now don't suggest anything you'll look like me. I love you some sun. We do classify burns. Like I said, we've got the first, second, third that you may see. However, there are some other ways of classifying a burn, and those are basically through depth and extension. That's how we're classifying them. From the epidermis down the dermis into subcutaneous tissue through the subcutaneous tissue. So you have superficial, which is basically on the top. Give me an example of superficial. That would be your sunburn. Then you have your superficial dermal. So now it's kind of gone into the dermis. What do you think you would see as it starts to progress down into the dermis? Fluid blister. So those of you who have actually had a sunburn that's got blisters all over you, that's not your typical first degree burn. That's more into your second degree burn. And that was that gentleman that came in, and we literally had to give him pain medicine and fluids and the whole 9 yards because he had most of his body had first and second degree burns. So you can put a central line in if you need to, but if you don't, you're gonna find a place because he's gotta have a line. That's part of our treatment plan. If it's really bad, we may do a central line. It just depends, and we'll see some pictures of some really bad nasty. Deep dermal is where you have those blisters are now surrounded by white tissue because you're getting down into the subcutaneous, the fatty areas. So it starts looking different. As it progresses downward, that burn area will look totally different. We'll look at that. So first degree burn, you can see on the hand, it's just the surface area. Second degree, you got the blisters. Third degree, you're actually down into the subcutaneous tissue and it's starting to look dark. It's very discolored. It's blackened, maybe leather. Not much circulation there. It doesn't blanch very well. This is how we're going to characterize it. This is the one you need to learn. This is the most, probably almost the most important slide that you have, because it not only gives you the type of burn and how much of it is considered burn, but it also gives you the clinical presentation and your treatment, all on one slide. So as you can see, there's 4 different ones. You've got superficial partial thickness, You have deep partial thickness, and then you have full thickness. So there's kind of like, remember our blocks, there was like 1 and then 2 2s and then 1 3 third degree. So it's the same here. You've got first degree, which is your superficial. Your second degree is both of them. One of them's going to be the superficial partial thickness, and the other one's going to be the deep partial thickness. And then your third is your full thickness. Now, you might hear in some places say that there is a fourth. And fourth, they're really just meaning that it's the bone. You're just seeing the bone. But really, if you've gone through the subcutaneous tissue, you're looking at some muscle. And that's pretty extensive. But you may hear some people say a fourth degree. And a fourth degree is past that subcutaneous tissue into the muscle, tendons, and bone. All right, so you've got a superficial first degree. What are you going to do with that? It's just red. It blanches when you press on it. You know, you have good capillary fill on there. What do you do with your first degree burn? Lotion. You might put some lotion on it. If you're going to use some lotion, then you want it to be a very basic lotion. And it's basically used just for drying. But I'm going to give you a secret because I've probably burned way too much because I'm pretty fair, blue-eyed, freckles. If you use vinegar and water, it actually takes the burn out. It's the best thing ever. I'm going to tell you that right now. It stinks. It's so worth it. It is just so worth it. So if you get really bad burn, I'm just telling you, try it. It's fabulous. So basically, the skin's intact. You don't have any blisters. You have a normal capillary refill. It's just kind of a sunburn. So NSAIDs, because it is inflammatory, right? That's where you're getting all the redness, and that's where it is starting on that inflammatory response. So we want to use some NSAIDs. You don't need any hardcore stuff. We want to stop the burn. So initially, you want to put some cool compresses. So this is cool water with some vinegar. That's what that is. Okay? So what are you going to tell your patients? You're going to tell them to drink a lot of fluids. The thing about burns is you don't really know how bad they are. Probably the first 2 or 3 days. You don't really know what where it's going to end. And, you know, it starts in one spot, but it does spread out. And if you don't get resuscitation and stop the burn immediately, then it will progress. So what we want to do is we want to cool it down, make sure you're drinking a lot of fluids, give them some NSAIDs. On your superficial partial thickness, now we have blisters. We got the blisters. You got some swelling, maybe weeping. The nerve endings aren't exposed, so it's really painful. You know, these are some really painful burns. So we're going to use some kind of NSAIDs. If there's a lot of it, then we may actually give them something for pain. Okay. As far as the blisters, have you ever heard not to pop the blisters? Okay, don't pop the blisters unless you have to. Now, if it's a really large surface area, you may not have a choice. You may have to debride those, and we'll put some dressings on there. But try not to pop them. If you've got, like the guy that came in that had just like little blisters on his skin, we're not going to pop all over. We're just going to let them be. We're going to gently cleanse them. Okay. Healing takes about 1 to 2 weeks for that second degree superficial partial thickness. The deep partial thickness, we're going through the dermis, okay? We've gone from the epidermis and now we're through the dermis. This is the entire dermis, deep layer. So now it's kind of looking weird, right? Your skin looks really strange. It's not red. It's not this waxy. It's a waxy color. So remember waxy. That's the way that they're going to describe your deep partial thickness all the way through the dermis. It'll be waxy white, light pink, that kind of thing. So you may have just a pale center, and then it kind of comes out a little bit with the pinkness and redness. So the center, actually, you press on it, and it's not painful. You can sense that somebody's pressing on it. But that center is not painful. However, what surrounds it is painful. So they're still going to have a lot of pain. So that is topical. We're gonna put some topical antimicrobials. We're gonna dress it. We may have to put, if there's a large area that we are having to debride that, then we may have to put a protective layer of skin on there. I don't know why it's losing me. You know, when they take it off of you and they graft. The word was not there. So that you may have to graft it if there's a large area. Healing takes 3 to 6 weeks. Now, if you get to the third or the full thickness, now you've gone through epidermis, the dermis, down into the subcutaneous tissue. Okay, that's all destroyed. Okay, you're not getting that back anytime soon. All right, that is leathery. There's no capillary refill. You have no perfusion to that area at all. There's no capillary bed to give you perfusion to that area. So it doesn't exist. So it's tan, brown, leathery. They're going to call that eschar. So they're going to describe it as leathery. So if you get to leathery on anything, NCLEX, R exams, whatever, you're going to be like, oh, that's 3rd degree. That's not good. And we're going to call that an eschar. Eschar is a black looking area, and that has to be removed. Like you have to remove, if you're at a full thickness 3rd degree, you're having tissue actually taken off. So then you can get to part of tissue that can have some capillary beds and regenerate. So we'll have to debride those. But so you can have contractures with these as well. You can have contractures with your deep partial thickness because they don't want to move them if it's like over the hands or the knees or something to that nature. But you can have contractures, especially if you have muscle involvement. There's no pain. They're not going to have any pain. You can poke it, stick it, whatever you want to. There's no pain. However, remember, as it comes out, you will have some pain in those outer areas. You just won't have any pain there. And they're going to describe that again on an exam. Will be leathery without pain. So if you see it's without pain, it's a 3rd, 4th degree, period. It's the full thickness burn. So with these burns, if you have anything over 5 to 23, you're going to have to give some fluids. You're going to have to resuscitate them. This is very serious. So this takes months. It's going to take months to heal that tissue. They may never totally get it back. So this is your superficial. It blanches. It's red, painful, but it's minimal tissue damage. This is your superficial partial thickness. So you can see here you got blisters, but it looks like there's actually a variety here. So whatever burned this person, we have different layers or different levels of burn on this person. But you can see the blisters here. And what's in between looks like, where the arrow is, looks like it's a little bit more depth there. So blisters, they can be open, they can be closed, leaky, wet, pink. You still can blanch it. So if you put your finger and try to get a refill, you can still blanch that tissue. So it still has some perfusion to it. So that's a good thing. Again, don't pop them unless you need to. The small ones, leave them be. Just cover them. If they break on their own, then that's when we actually start putting some stuff on there to make sure that we're protecting ourselves from infection. So your deep partial thickness, now we've gone through the dermis, most of the dermis here. And you can see the red areas, that's where you're having a lot of the pain. But if I pushed in the middle there, I would have little to no cap refill. And you can feel pressure, but the pain is on that surrounding tissue, not on that middle tissue. And you can see it looks a little discolored there. It's like, it's not easy to differentiate the tubes as well. Now, if I have blisters, that's an obvious, that's your superficial partial thickness. But when the blisters are gone, you really have to start trying to blanch it to see what kind of pressure you can put on it and those type of things to try to differentiate between the two, especially when it's a small area. And then finally, the full thickness burns. You can see by the hand that we've got our tendons there and bone are gone. So everything's gone off the top of that hand. Yes?
Top two is that third degree, the bottom would be fourth degree.
If you came in to where I am, I'm saying that that's a fourth degree. If it's down to the bone, it's a fourth degree. But they're not going to necessarily classify that as a fourth degree on your NCLEX exam because they're only going to recognize those four. And they're going to say it is superficial partial thickness, and that sort of thing. It doesn't have pain except for the surrounding tissue, but they can sense that you're touching them. So even though the center is not painful, the tissue surrounding it is very painful. So they're still going to complain of a lot of pain. It's just not going to be in the center of that burn. Okay. But you can easily see here that you're not getting a cap refill in this thing, right? None of these. It's black. It's charred looking skin. Even if you didn't look at the hand, I mean, if you got the other two, you would know for sure that this is a full thickness burn. So again, some of the tissue around it, even if you looked at the foot there, you can see the pink that surrounds that blackened area. They'll still have some pain in that area. So they're still going to have some pain. It just won't be in that tissue right at the burn. Okay. So deep, full thickness would be your fourth. That's what we call that. You can see the little hand up here has no fingers. No, anyway, no fingers up there. And you can see the hand here. They might be able to say that. This to me looks like an electrical burn. Like they grabbed something and it went straight up his arm. That's what it looks like to me. So subcutaneous tissue, tendons, and bones. This is what we were talking about earlier. This is what it's called. When you got the center of coagulation, everything is coagulated together, it's denatured and just ran together like a bunch of goop, nasty stuff. So that's your necrotic area. There's no blood flow to that area. The surrounding, we call it stasis. That's where you get a little bit of vasoconstriction. You've got a reaction to that area, so you've got the body's trying to heal it, so you'll have some clotting that's going on to try to prevent anything else coming to that area. Fibrin deposits, it's just trying to protect itself with that injury. So the cells are still viable in that stasis area as long as you get the perfusion back to the area soon enough. So those are the ones that you need to get that fluid in as soon as possible. You need to stop the burn first to get the fluid in. We're trying to limit down to just that coagulated area. The hyperemia, there you have like vasodilatation because you have a burn, right? It's trying to pull itself off. So you have the vasodilatation, you have the permeability with the vessels, but you have a minimal cell damage. So that we're going to keep as long as we save our patient. If there's not a whole lot and you haven't saved your patient, you're going to keep it. But so you can see on this breast that the center is just gel, just coagulated, followed by the stasis area, which just surrounds that. And then you have that very pink of the outer area, which gives you the hyperemic area, okay? So that's what they're gonna look like. Those are the areas that we're trying to save. So, when you have a burn, what do you think is an area there's a few areas that we really need to be concerned with. Obviously, the face is a problem, right? Okay, so why is the face such a problem? Airway, because it's our airway. What else is on our face? Eyeballs. So airway and eyeballs, that's a problem, right? When they come in and they have facial burns, you already know that they were in contact with something very hot. And they probably breathed it in. So you assume immediately if you have any burns on the face that we have an airway issue. Immediately gonna assume that, okay? So it's important for us to know, when did this happen? Did this just happen? Because as you go further into the experience, swelling increases. So you have a very limited amount of time in order to save your airway before the inflammatory process closes it off. So we have to recognize very early on whether we've got an airway issue. So what are some indications that you would think in your head, like, oh my gosh, I think we probably have some airway involvement? Singed nose hairs. So if you look, because you're going to look all over the face, right? A lot of times their hair will be singed off, eyebrows, and the nose hairs. People don't think to look in their nose, but if they've inhaled that particulate and it's burning their airway, then their nose hairs will be singed and their nasal passages will be red and inflamed as well. And you may even see some soot when you look into their nose. So what is one of our assessments that we're going to do immediately? Okay, okay. I'm going to assess your airway. Okay, I'm going to look in their throat. I'm going to listen to their lungs. If my airway is closing in, what do you think I'm going to hear? You're going to hear some stridor. What else might trigger while I'm talking to you? What else might trigger that? Oh, hoarseness. If you hear they're talking to you and they're hoarse, if they've gotten a stridor, we're we're behind the 8 ball. But if you are talking to your patient and they're very hoarse and they have singed hairs anywhere, they've got cherry red lips, their nose is really red, you better intubate that patient now. Like, you have a very limited time to put that airway in. And so you'll see they'll come in talking, and then we're putting them down. You're like, oh, okay, well, what just happened there? It's because it's just a very hyperemic. You're going to close your airway off if you don't. Okay? We'll worry about everything else later, but we ought to have an airway. So for our face, we want to look at our eyeballs. We want to make sure that we don't have corneal abrasions. But we are going to most likely intubate this patient. Lips, like your lips, are real sensitive, and so they will swell up like no tomorrow. Your eyes will swell up like no tomorrow. So we want to make sure that we just clean those off as best as we can. But don't forget the eyes, because they may have to have some antibiotic cream in them because we have corneal abrasions. Has anybody ever seen a corneal abrasion? You've had one, yeah. So the way that they detect if you have a corneal abrasion, sometimes you can't see them, but we put this little dye in your eye and we rinse out most of it, and then we take a blue light and we look in there, and if you have an area in your eye that says, hey, with this dye, you know it's a corneal abrasion, some type of an abrasion. A slit lamp. Well, slit lamp is where you can look into the eye, yeah. So that's one way to find it, absolutely. So anyway, we want to make sure that we treat the corneal abrasions. We don't want anybody to go blind, right? I don't do that. Bacitracin cream and ointment is one of the ointments that we will use, or the creams that we will use for the face, for the burns on the face. The hands and feet are also important. So we know that the face is important because, I mean, obviously that's our airway, the way we see, and it's disfiguring, right? So it's important for us to immediately start treating the face. Why are the hands and feet so important? Huh?
Quality of life.
Quality of life. If they lose their functionability, then they're going to lose their quality of life. You don't want them to lose a limb. So the hands and feet, if you burn your face, hands, feet, and genitals, you're immediately, I don't care how bad the burn is, you're most likely going to get a trip to the burn unit. Because those are so hard to treat, first of all, but we don't want to lose them. We don't want to lose any of them, right? So deep wounds, we have to do grafting. Like that one there is definitely going to have some grafting. Dressings, when we're putting dressings on, first of all, if I burn my hand, most likely I have circumferential burns. What does that mean?
All the way around.
All the way around. Well, if you've got swelling all the way around on any kind of limb or joint or finger or whatever, what happens? It cuts off circulation. So we'll have ischemia. Well, we don't need that, right? So we have to be really careful when we are putting dress. First of all, we got to get the swelling out. Excuse me. But we want to make sure that we're not impinging that circulation even with our dressings. Okay? We're going to dress each limb by itself. We're not going to wrap the hand. We're actually going to wrap every single finger. We are going to use these measures to keep our hand from contracting, from the muscles pulling it in, and not able to straighten it. So my husband had knee surgery this past week. It was fun. It's been a really fun week for me. I've gotten a little bit of sleep, not much, but we didn't see the doctor yesterday because I wasn't happy with the way it looked. And so what they said was, it's easy for us to get bent. It's difficult for us to straighten it ever again. So if you lose the ability to straighten, it doesn't come back because you have so much scar tissue. I was like, oh, that's important. I'm not an ortho nurse, so that's important stuff. So I'm like, straighten it here. So he's got all this swelling and he's trying to straighten it. But with these, you can see there's two different kinds here. And we're going to want them to use their limbs during the day. So there are a lot of PT, right? But we're going to straighten. And we're also going to have periods of, or depending on where the burn is, we may actually have them have stuff in between their fingers to keep it separate. So we get full functionality out of it. So every little thing that we use is to maintain functionality. Okay? We don't want to keep it like this, because we'll lose this, right? So we'll still have somewhat of a grip, but we're not going to be able to straighten out the fingers. So, what is this thing over here in the corner? What is that glove? It's a compression sock. It's important for us to use those compressors because it keeps the fluid out, and it is measured to that person's hand or leg or body. So they actually do measurements and they make your very own compression stockings. So it's important for us to make sure that, first of all, we dress it appropriately. We're not impinging any more circulation. Keep the fingertips open so you can do your capillary refills. Because if your fingertips ain't getting nothing, neither is the rest of it. So we want to make sure that we leave those exposed. And we're going to elevate to keep the swelling down. If we have a bunch of swelling in one area, what would happen to that area? Y'all say that? Compartment syndrome. So you can imagine how if you've got a hand like this, you can get compartment syndrome very easily. So keep the limb elevated, compressed, stressed. So let's talk about assessment. We kind of talked about it already with our face and that sort of thing. So the face and the neck are important as far as trying to make sure that they have adequate airway and breathing. And then the corneal abrasions. Now, if you burn your chest and you burn a good part of your chest, it's still an issue with expansion. So if I have a circumferential burn on my torso, how am I going to expand in order to get a breath, an adequate breath? So basically, I'll show you in just a minute, but yes, so we're going to have to help them expand. And it's going to be the same, it doesn't matter where it is. So if I have circumferential burns on my arm and it's impinging circulation, I'm also going to have to do some surgical intervention with that as well. So circumferential burns are the worst. They're the worst. Because it does cause hypoperfusion. So with this particular person, she has extensive burns, and she has extensive burns on her chest, and so they did an eschorotomy, and they basically had to cut into her tissue, and you'll learn, I think, have they done the limbs yet? Oh, okay, so you'll learn about compartment syndrome on the limbs as well, and you will also have to cut into that tissue in order for it to have room for expansion. So you can see here that they basically just cut the skin open, so then her chest wall could move, could have movement. Okay. All right. So how are we going to calculate the extent of this burn? We're going to use the rule of nines. There's a couple of different things we can use. There's a Browder and there's a rule of nine. So this kind of starts that rule of nines here. An increased amount of total body surface area equals an increased percentage of your mortality. So if you have a very high percentage, then you're most likely not going to make it. Your prognosis is not that great. So we typically worry about those that have the second and third degree burns. First degree, if it's all over your body, 99%, you probably will need some fluids and some NSAIDs or something. But the second, third degree, that's where your shock state comes in. Okay, so it's really important with those that we get our percentage, our TBSA percentage correct, so we can give them the amount of fluid to keep them from going into shock and death, really. So one little rule that we have is the rule of palm. And I love this because nobody comes into the emergency room with just the forearm, and it's really, really beautiful because it's from here to here, or it's just the torso from here to here, and the whole thing. They don't do that. A lot of times it's a flash burn, or it's a splash burn, or it's just one area that kind of comes across the body or something of that nature. If there was clothes on, you may not see it there, but so it depends on what kind of clothes you had on as to how this pattern is going to show up. So super cool thing is you can take your hand, this is 1%. If it's a little baby, you can take their hand, and this is 1%. And you can say, okay, 1, 2, 3, 4. Okay, so this is 4%. You see what I'm saying? I can say 1, 2, 3, 4, got a little bit there, 5, 6. So I can at least get an idea about how much percentage I have. So rule of palm's really nice, especially when you got some kind of funked up pattern, and it's hard to differentiate. Otherwise, we're using the rule of nines, and that's what you're going to use on your exams. We're not using anything else. We're going to use the rule of nines. And so you need to memorize this chart. But let me just tell you, if you go 1, 2, 3, 4, you will have your rule of 9. So if you forget, you can literally sit there and count how many palms you have on your body and be like, oh yeah, that was 18. You see what I'm saying? So don't freak out, but you have to know this in order for you to get probably 6 questions right. Okay, so you need to memorize this chart. The head, all of the head, the whole head is 9%. So if I only did my face, what's that? 4.5, okay? The whole front is 18%. So if I just did from belly button down, what is that? 9, okay? If I did only front side of my arm, how much is the front side of your arm? 4.5. You see what I'm saying? So you have to know your rule of 9. And that's the way it's going to be described. We're going to go over some of those in a few minutes. But genitals, 1%. That's the only difference. So legs, 18, 18, 18, 18 on your back, torso, 9, 9, 9. Okay? This is the London Browder classification. It's very useful in your kids. It's very specific. That's what this is. It's just really specific. And so they'll use this with kids. And when you get to the burn center, they'll actually use your London Browder. We just need a down and dirty, what do we got going on? But they'll most likely use the London Browder. But Jurian, I've worked in several, they all use Rule 9, just so you know. All right, so burn care, very important. The very first thing you want to do, you want to stop the burn. Pull them out, pull them away, whatever it is that you need to do. Cool it off. Take the burning stuff off of it. Whatever it is, stop the burn. Your burn patients are considered multiple trauma until otherwise determined, because there's been times where there's been a MVC, and actually what it was, it turned into a burn victim because they had a crash that was on the pole, and it came down, and they got out of the car, and then they got electrocuted. So they weren't in the crash, but there's a crash. So you got to be real careful about asking your EMS, like, what happened? Like, what did you see? What do you think's going on? And that kind of thing, because you can have some really weird stuff. Okay, a lot of burns that we get right now are from meth labs. So guess where those burns are? Ear up. It's a BAM! So all hair singed, arms, the front of the arms down here, maybe some in their lap where it's just exploded on them. Yeah, so those are pretty easy to kind of note, but just know that you kind of got to get a backstory. You got to get a history of what's going on, but you consider them multiple traumas, so be careful. They could have broken bones and those type things, especially if it was electrical, because it's going to throw them. Okay? Always perform your ABCDEF. Always. That's just, we're talking about critical care. You're always going to start with your airway. So in our airway, if we're going to assume that there are multiple trauma victims, what do we do with the airway? Put a C-collar on. You might have to intubate. Put some, make sure it's open. That's the main thing, right? We're going to make sure it's open. We put our C-collar on just in case, that is an issue. B, of course, is breathing. So we may have to intubate them, put some oxygen on them. C, circulation. At this point, you want to start line because they're going to need it. And then, of course, neuro and all that. You're going to do your A, B, C, D, E, F, G. That's how you're going to treat it. So stop the burn, perform your ABCs. Determine the time of the burn. It's very important for you to know when they were burned, and you're going to figure out that in just a minute. Because if they were burned 2 hours ago, the way we treat them is a little bit different than they were burned, 30 minutes ago. And here they are. So time of injury is important. Avoid hypothermia. What happens with our triangle? We die. Okay, so, yeah, I mean, we get into acidosis and we have that whole cascade. Well, we don't want to do that because you can, from a severe burn, go into the IC. You know, it's a secondary cause, remember? But, yes. Yeah, pretty much. The deep second can start that process, the deep second. If you have enough of it. If you have enough, you're definitely gonna go into an acidotic state, absolutely. Okay, so avoid hypothermia, so you're going to cool them off, but then you're gonna cover them up. All right, they're not gonna wanna be covered because it's burning, it's hot, and you still have to cover. We'll cover with most likely, we like to cover them with a sheet. We can use some, for those deeper ones, we can use some sterile towels, you know, the blue stuff, and pour a little bit of water on those to help with the cooling process. That's very helpful, but they'll want you to stand there and do that like forever. So we try to get a line in and get some opioids on board. But we do want to cover them up. Remove anything that could potentially become restrictive or could retain heat. So if you have clothing that is stuck, do we pull it off? No. Okay, don't pull that off, but you cut around it. Okay, you just want to cut around that. You want all their clothes off. You're going to cut all the clothes off. So make sure you get everything off. But if it's stuck, they'll take that. They will do that. We're not going to do that, but they will eventually take that out in surgery if there's a lot of it. Now, rings are a problem. I've cut many a ring off. If you see that somebody has a burn on their hand and they have a ring, it needs to come off. I don't care if the burn's on this side and they have a ring on the third finger. It's going to have to come off because the swelling is going to go in that direction. So let's not cut their circulation off, right? Okay, so when do we transfer to the burn center? You don't have to know this, but you know, we want to transfer everybody there.
She said we don't
I don't
know
like
this.
burns.
Yeah, I don't.
Burns are bad. Burns are, it's not good. So this is the way we have to figure out if we're going to transfer them or not. 10% or more if they're under the age of 10. If they have the hands, feet, genital, all those things, criteria, those people are going to the burn center. Any kind of joint that's involved. Most of your second and third degree burns greater than 5%. If you have a third, greater than 5. But if you have a second and it's greater than 20%, we're going to send those. Any kind of inhalation burn, they'll go over to the burn center as well. All of these are really going to be dependent on your physician. Like, yeah, they're going to. They'll call the physician over there, and then they'll determine, yes, we'll take them. No, I think y'all can treat them there. We don't have any room, whatever. But this is just kind of one of those things where it's like, this gives you an idea of when you need to call. Okay, that's all it is. There's different phases of burns. You got the emergent, resuscitation, intermediate, and rehabilitative. I'm just going to ask you, what do you think emergent? What we're going to do in emergent? We're going to stop the burn. Okay. Let's see in resuscitation. That's the fluids. Does that make sense? Resuscitating them is fluids. So emergent phase, we're going to stop the burn. Resuscitation, we're going to resuscitate them. Whatever it takes to, you know, get them some fluids in, make sure that they've got enough oxygen, that they're perfusing. What do you think intermediate is? Okay, close observation. So this is phases all the way to the end. You also have a rehab. That's where in fact you turn the corners. Now we can worry about wounds and things like that. Rehab is where we're trying to give them that quality of life. They go and do so much physical therapy and all kind of mess in rehab, and that can last for years. So the rehab phase, the convalescence, what we call it, can last for years. So emergent, priority, stop the burn. Airway, breathing, circulation. Okay, you'll initiate an IV. Okay, because that's what we do in ABCDEF, right? We initiate IVs. You want all your baseline diagnostics. You need to know your pre-hospital history and care. Because when we actually go into giving them a bunch of fluids, it's from the time of the burn. So if you were burned at 12 o'clock and you didn't get to us until 2 o'clock, we're going to resuscitate you from the time of the burn. We're putting that into the equation, and you'll see what I'm talking about in a minute. Know when your burn started. Resuscitative, again, we're giving them fluids. And so the goal here is to treat that hypovolemic shock and to get them recirculated. Intermediate, this is where we have restored capillary permeability. So this is where we turn the corner here, okay? We've turned the corner, they're starting to diurese all that fluid we just put in there. So their kidneys are working, things are working. We finally turned the corner, things are starting to look good. We're hemodynamically stable. Now let's focus on that wound care. Now the fun begins. So wound care, wound closure, infection control, nutrition support, so important right here. Pain management and physical therapy. So the first two phases are pretty initial. That's your initial first 24 hours. And then intermediate phase is going to be after that. After that, they're going to they're going to start going into this intermediate third phase. And as soon as they're hemodynamically stable, we start working on their wounds and stuff. But we also want to make sure that we're feeding them and protecting them. And like I said, the rehabilitation, that's the final stage. Those are all restoring functionability. So cosmetic surgery, lots of physical surgery, that's where we have a lot of surgeries, lots of surgeries we put on. Now, so when we're talking about medical treatment and fluid resuscitation, it all is estimate on that burn size, right? I want to cover this part, this wound management right here. What we usually do is we do a topical antimicrobial agents and debridement agents. And the reason why I want you to lean in a little bit is because you have to debride the area. You have to get the stuff that's not good, not viable off of there. So if you have necrotic tissue, you have to get that off so you can get to the viable tissue and have it rejuvenate, right? So sometimes we'll do surgery, and then sometimes we'll use this enzymatic cream. And we put that enzymatic cream and it eats away at that top layer. Okay? Once we start seeing we got some pink, we got some kind of something that might actually, have some perfusion to it and might actually grow, then we'll start using our antimicrobials, or even if we have to, we may put a graft on it as well. So sylvadine is what we call it. It's silver sulfatadiazine. It's sulfa. That is a sulfa drug. So it's an antimicrobial, but it does have some enzymatic debridement in it as well. So it's kind of both. We use that a lot on our burn patients. I love this stuff. It's amazing. If you burn yourself and you got a big blister and you put some of this and wrap it up, man, the next day is beautiful. Love me some Sylvanine cream. But if I'm allergic to sulfa, can I take that drug? No, I cannot. So they'll have to use something else. So if we're grafting, so let's say we decided to graft because we have a very large area and it's unprotected. So we need a graft on there. So what we're gonna do is we're gonna try to use the patient's own skin, because you won't reject that, right? Because it's your own. Yeah, we love us, we love ourselves, right? Where do you think we're gonna take this tissue from? Legs, your thighs, your butt, your back. We want good sized sheets, right? So we need a large surface area to use. And literally right here, you can see they scrape that layer off. They literally scrape your skin off. They put it through this little meat grinder thingy, and then it comes out as a mesh, which is what you're seeing over here. And so they can take that little bitty piece of skin that they took off right here and make it a big piece of skin. I put all the little holes in it and they stretch it out. So then they will form new skin cells. So it'll eventually fill its way in and cover it up. So you have to, in order for you to get this, you got to get down to where you see all these little blood vessels. You got to have viable tissue. You got to get down to the little blood vessels. So there's different kinds of grafting. Autograft, that's your own. That's my own skin. Making my own skin for myself. Allograft, that is a cadaver. Who wants cadaver skin? So they got some. If you don't have enough space, they're going to use cadaver. And then there's xenoform skin, and that's pig skin. So the only skin that you're actually going to be able to grow and it's not going to reject is going to be your own. The rest of them, we have to cover you up. You're going to wind up with some crazy infection. So we have to get you covered up. So I think they're doing fish.
Fish? Hey, yo,
Yeah.
can I breathe
So
underwater?
They
Like
actually use
fish
fish skin.
Scales.
We have to cover it up.
Is it gonna let me breathe underwater?
So we've got different things that we can use, different substances,
Be dope.
but those are the three that you need to know. So they can take your own skin and grow it in the lab. So if they don't, you're going to get like a cadaver, you're going to get a xenoform until your skin gets finished growing and it's enough to put on you. That's what they're going to try to do. Okay? So then you don't reject it. All right, so some labs. Labs are really important. The first thing we're going to do when you come in there, we're getting all your diagnostics. So we're going to need to know what your baseline is. What do you think your CBC is going to look like if you have this large burn and your fluids are shifting and all this crazy stuff? Okay, so it's going to look like you have not much fluid in there. That's what it's going to look like, right? So everything will be a little elevated. You're going to have a little bit of an elevation, depending on when you do these labs, of course. But so we're going to have a high white count, aren't we? I mean, yeah. So we're going to keep an eye on that. But you're going to have an increase in white count. Your CBC, remember this is a fluid and electrolyte thing. I have got destruction of cells. What comes out in the cell when we destroy it? Potassium. So you're going to have an elevated potassium level because it's being released into your circulatory system. Okay? So we have to be really careful with that. And that's why an EKG is on here. Two reasons. One, because we're going to have an elevated potassium, and if it's an electrical, then we're going to have to make sure that you're still not in some type of dysrhythmia. ABGs, what is carboxyhemoglobin? Okay. It's like a carbon monoxide, right?
Expected?
Have you heard of people dying of carbon monoxide?
It's not abnormal, it's expected.
So what happens is we have the release of this carbon monoxide, and it loves some hemoglobin, loving us some hemoglobin. So it will displace our oxygen off of our hemoglobin and be replaced with this carbon monoxide. Now, does that carry? So I have all of these cells. I got plenty of red blood cells. I've got plenty of hemoglobin. I just don't have enough oxygen. Because now I've got this carbon monoxide, this carboxyhemoglobin is what we're gonna look for. So, if I do a O2 sat on somebody to try to see what our oxygenation is, and they have an inhalatory burn or whatever, what is my O2 sat gonna look like? Yeah, it's actually it's gonna look good. Oh, yeah. Oh, girl, you good. I know you got some nose hairs that are singed and your eyelashes are gone, but girl, you're fine. You got, look at this right here. You got 100%. Unfortunately, our O2 saturation monitor just looks at our hemoglobin. It don't care what's on there. It's just counting it. Like, yeah, that's 1, 2, 3, 4, okay. We're good. So don't look at that. That's not accurate. What we need is an ABG. And with our ABG, they're going to give us our carboxyhemoglobin. So they're going to let us know, red flag, it's real high, you might need to intubate, or, So how do we treat a high carboxyhemoglobin? How do you think we should treat that? I mean, push some oxygen. You got to push it back off. So we're going to give them a high flow oxygen. Okay, if we don't intubate, then they're definitely getting some high flow oxygen for sure. What do you think our coags are going to look like? We're in like a surge, shock kind of state. Probably going to be elevated. Okay, we could see that our coags are starting to elevate. We've got to watch those for sure. But we do want a baseline, right? What about why are we getting a toxicology screen? Okay. Yeah, so what if it was a meth lab? What if they had a lot of drugs in their system and they're a user and they're in shock and half dead, and I'm gonna pull them out of the grasps of death and try to treat them? What we need to know is we could have deliriums and we can have all these other comorbidities along with this burn victim. So now we're dealing with a burn and all of that, plus their comorbidities. So we need to know what that toxicology screen says. Urinalysis, we'll have a lot of crap going through the kidneys. Remember, fluid electrolytes, we've got denaturation of these cells. Stuff's going to be released. What filters your blood? Your kidneys. So we have to watch the kidneys very closely because they can take a big hit. So our creatinine and BUN, we'll watch those closely. With the urinalysis, you're looking for any kind of myoglobin, you're looking for color, you're looking for specific gravity, because what can happen when you get muscle damage is it has to go through the kidneys, right? So it can clog those tubules, and now we're in acute kidney injury, acute kidney failure. So myoglobin will give a CPK. An increase in CPK just means we've got tissue damage, we've got muscle damage somewhere. Increase in CPK is muscle damage. But specifically, a urine myoglobin will tell us that we have a lot of muscle damage and that we have to watch our kidneys. Okay. A chest X-ray. If you've got shifting fluids and you are hypoperfusing and all of that goes along with it, forget the fact that you may have an inhalant which will cause inflammation inside your lungs. It can trigger ARDS. So all of these things we have to watch. You can get pneumonia if you're not up and about, right? So we need our baselines for sure. But CAT scan just to make sure there's not any other injuries that we've missed. All right. Did you have a question? So that is rhabdo. So rhabdo is the release of myoglobin and it gets stuck in the tubules and it causes acute kidney injury or failure. But what you would see with rhabdo is a really high CPK. And then, of course, myoglobin. All right. This just breaks it down into what to do for each one of those different ones. I'm not going to go over that. We don't really have time. So just remember this slide because it's very specific. Don't use ice or butter or whatever these crazy people want to do.
That's actually, I had a burn patient, and when I did this part, I'm telling you.
Yeah, don't use oil. Don't use ice. Ice actually constricts the area even more. You've already got poor perfusion to the area. It causes the burn to actually get even more deeper. So don't do that. Even though it feels better, right? So resuscitation. In resuscitation, I told you we're going to talk about how to resuscitate. You first have to decide how much percentage of the body has been burned. So what is our VSA percentage? You're going to take that percentage and now we're going to use the Parkland formula. And the Parkland formula is going to give us the total amount of fluids that we need for that particular patient's weight and percentage of body burn. Okay? And again, this is for your second and third degree. But this is what you're going to use. So remember this one. This is the Parkland formula. You have to know this. 4 milliliters of lactated ringers times your weight in kilograms times the percentage of VSA. The rule of nines. Okay? So you have 4 milliliters, and we're using lactate because it's got all the stuff in it, right? Plus your weight in kilograms, or times the percentage that you got from your rule of nines. That's going to give you your total amount of fluids that this patient's going to need. Now, we have this total amount, and we need to break it down. Half of that amount will be given in the first 8 hours. If you have 4 liters that you're supposed to give this patient, you have to give it within the first 8 hours from the time of the burn. So what I say, they came in 2 hours later, right? Now how much time do I have to get all that 4 liters in? I got 6 hours to give it. Okay, does that make sense? Okay, so it's time of the burn is where you're calculating the first 8 hours. That's why it's important to talk to your EMS. When do you think this happens? Well, I think it happened yesterday. So the first 8 hours we got taken care of. Half of that fluid's going in the first 8 hours. The other half is going over the next 16 hours. I don't care if you want to break it up into second and third eighths. It don't matter. Just do 16s. It's so much easier. So if I have 4 liters that goes in, half of that goes in the first 8 hours. I got 2 liters that's going in the first 8 hours. Now I'm going to give 2 liters over the next 16 hours. Okay? All right. It's important. You got to know this. We're not going to go over that. Okay. These are some of your complications. What have we told you about complications? You need to know your complications. Okay? So burn complications, when they start, when all that diuretic phase kicks in and we're starting to then transfer fluids around again, these are some of the things that you may see. Acute kidney injury, we already talked about that, but you may see acute kidney injury. Paralytic ileus. What is a paralytic ileus? It don't want to work. Not like that, just don't want to work. Okay, sorry, testing it ain't working. So things can leak out of that and it can cause major problems. So we need to get that gut going as soon as possible. We want to feed them as soon as possible. That's the only thing to prevent them from getting a paralytic. If you don't use it, you'll lose it, right? So in order for us not to lose our intestines, we're gonna use it. But watch for paralytic ileus. How do you know you have a paralytic ileus? Vowel sounds. We're listening for hypoactive or no active vowel sounds. Of course, they're going to be nauseated. They're going to have other GI signs and symptoms. Curling's ulcer. When you are stressed and in a hypermetabolic state of stress, especially, you are at risk for ulcers. So every one of you probably have a Curling's ulcer. Okay, so you already know how this feels. Nobody's stressing here, right? So, but when your body is so stressed, it's under so much stress, it increases the gastric acid and so on and so forth. So you can get what they call Curling's ulcers. And we see this a lot in the intensive care unit. So we need to prevent that. And what we're going to do is we're going to wind up giving them some medications to prevent them from having a Curling's ulcer. What do you think we're going to give them? Sulfate. Yeah. So what does that do, though? It coats your stomach lining. So there, and you can use a PPI as well. So sulfate, Reglan. We're going to use some Reglan, and we're going to use some Carafate. I don't know. I can't say any of those. So Carafate is your sulfate. No, it's Carafate. Put Carafate in. I can say that. And then the generic of that is sucralor or whatever. I don't even know how to say it. So, and then Reglan, those type of things that just keep the gastric acid and keep it moving. The hypokalemia, hyponatremia. So once you get into the diuretic phase, we're just peeing everything out. Like everything's going. There's so much fluid, we're just peeing everything out. So you have to be really careful. Once again, we have those shifts in electrolytes. So now we have hyponatremia. What signs and symptoms would you see with that? Neuro. So we'll see neuros with those. And then the hypokalemia, you're going to see some muscle, you're going to see heart. Excuse me. There's like just evaporative fluid loss through your wounds. You're going to lose, we lose fluid as we talk and breathe every day, right? That's normal. But when you have all these open wounds, they're weeping. You're going to have some evaporative fluid loss through the wounds as well, so you have to be really careful with those. So it is a balance between fluid and electrolytes with your burn victims. So wound healing. We're going into the wound healing phase. Pain control is so important. If you're going to take me and scrub my wounds, please give me something before we go. Can we do that? So before my husband goes to his physical therapy, where he's going to have to bend his knee in awkward directions and they're swollen, we take a pill. Like 30 minutes before we go, we take a pain pill. So, we're going to do the same thing with anybody else. If you have all these really painful wounds, we're going to administer analgesic 30 minutes before we go to have them cleaned. We're also, we have to think about their intake. Because again, we want to feed the gut as soon as possible. They have to have the nutrition, they have to have a bunch of protein and carbs. So we're also going to want to either feed them before we go get their wound care, or about an hour after we come back, we'll try to feed them. So that's important as well. So pain relief before we go, please. Closely monitor vital signs because it drops your respiratory rate, remember? Let's see, what else? Make sure that we've got output. So monitor that output. That's how we know where we are. Are we in the diuretic stage or not? Well, you're monitoring output. So 0.5 milliliters per kilogram per hour is kind of what we use. So just a half a milliliter per kilogram per hour. And that gives us approximately 30 milliliters an hour. That's why we just say at least 30 milliliters an hour. Weigh your client daily, so then you know how to monitor things. Monitor circulation status, always. Promote maximal nutrition, we talked about that. NCLEX is gonna ask you, we may ask you, what kind of diet that you need. It is frequent, small portions of high protein, high calorie, high carb diet. You wanna add in some vitamins and minerals with that, so we can have, enough, vitamin C in order to repair, right? So we talked about that. Preventing wound infections. So we try to put everything in a controlled environment when we're dealing with their wounds because a lot of times they will die from an infection. That's what they die from. So we don't want that. We've already pulled them through the worst part of it. Let's not do that. So dressing changes are all sterilely done. When they go for their hydrotherapy, they're only exposed for no more than about 30 minutes. Because you don't want to have a lot of electrolyte loss, you don't want hypothermia, and you don't want the exposure. So, and we talked about separating your eschar in order for you to have healing. We talked about that. You can look over that. So we have okay, so here's your little birds thing. Breathing body image is important. Urine output is very important. Rule of nines. Gotta know how much fluid to give them. Nutrition and shock and sylvaning. So that's what burns means. Okay. This is what can happen. You can have the worst of the worst and come out all right. It's amazing to me. It's totally amazing. Okay, I want to do one more thing with you guys. We don't have really very much time.